Let's now make a quick announcement just to start this session. Please remember to mute yourself. Remember to mute yourself during this discussion. If you have a question, you are feel free to post it in the chat box or raise your hand. But remember that we have a Q&A time dedicated late after discussion with the speakers. So just to highlight again that this is recorded. So note that you are recording your voice, your face, your name. So by continue with us, which we are really looking for, you consider that we are allowed to record yourself during this discussion. Thank you very much. Allow me to jump and introduce the speakers we have today. Now, actively, we have Dr. Patrick Piotie, who is a medical doctor and has a PhD. Patrick is a public health expert with over 20 years of experience, specifically in NCDs intervention, health system strengthening, and policy advocacy across Africa. He's a co-founder of Diabetes Research Center attached to the University of Pretoria, where he lead a research and chair the Diabetes Alliance South African leading stakeholders diabetes platform. With a medical degree, MPH, and PhD in public health, Dr. Patrick combined clinical insight and public health strategy to increase, advance, innovative, community-based and medical health integrated approach to address NCDs in Africa. And note that he's a 2024 Kofi Annan Global Health Leadership Fellow, and he's dedicated to amplify the voice to advocate and against NCDs, specifically to vulnerable communities. The next speaker is Dr. Olivier Munyemana, who is a medical doctor and executive director of Youth Empowerment Scholars Initiative, EAF Rwanda. And this is a nonprofit dedicated to equip young people with the skills and opportunity to drive sustainable development change. With a strong background in clinical practice and community health, Dr. Olivier have been led a great initiatives such as substance abuse reduction program, partnering with various organizations, including WHO, Rwanda Biomedical Center, and partners in health here in Rwanda. The next speaker, we have Dr. Weyoms. Dr. Weyoms is a pediatrician, public health scholar with over a decade of experience in clinical care research and community health. She's currently serving as director of program at CMADI in Nigeria, which is a leading project on environmental health wash and primary health care for underserved population. She holds a PhD from Leeds Beck University in the UK, and now she staff and conduct research at Newcastle, Bradford, and Arden University on maternal health, health inequity, and digital health. The last not least speaker, we have Mr. Abdul Karim, who is a research associate at the University of Liverpool, and he's an expert in health inequality, especially for cancer. With background in medical science and public health, he completed MPH, Master in Public Health, as a Commonwealth scholar, and he's now with international experience from all over the world, including Swaziland, UK, Nigeria. Now, he's a proficient in health data science policy research and program implementation. With over 5 years of experience in global health intervention, Abdul Karim, he's aspired to advance population health and reduce health inequality worldwide. Please join me to welcome our special important speakers who are going to take through the journey to improve African health population right now. Please feel welcome our speakers. Please allow me to take you through a brief introduction on our fireside chat. The theme is Equity in Action, which is focused on addressing the NCDs burden in vulnerable communities. Just by now, 43 million deaths are happened due to NCDs worldwide. In Africa, we have a huge rate of NCDs just because we have a weak health system, poverty, gender inequality, limit access to prevention and the care of NCDs. Those are the contributors to this huge burden you have in Africa. By going to discussion with those special speakers, we are going to go by answering these like 5 objectives to understand the burden and structure drivers of NCDs, to understand the equitable intervention required to address NCDs, to explore the policy and advocacy option for NCDs intervention, and the role of stakeholders while inspiring for action and sustainabilities. Everyone, welcome to the Engage Africa Foundation Fireside Chat 2025. By exploring how burden is NCDs in Africa and what are the contributing factors, let's start by Dr. Patrick to explore this. Dr. Patrick, to explore the factors contributing to NCDs, especially in vulnerable communities. What are the social and economic drivers of inequity in NCDs outcome here in Africa? You can share with us. Please, the floor is yours.
Thank you, Michee, for your question. And good evening, good afternoon to colleagues and friends and brothers and sisters from the African continent. It's a pleasure to be joining you guys today. Indeed, as you rightly say in your introduction, non-communicable disease are slowly or fastly becoming a serious issue on the African continent. It's really critical that as Africans, we start engaging and discussing how we will address this challenge of our lifetime. When you look at equity in NCDs, it's critical that we understand the context. Obviously, for the longest time on the continent, we've been dealing with communicable diseases, whether it's malaria, HIV, tuberculosis, and the likes, cholera, and such. So our health system tends to be focusing on those challenges. However, with the increase or the rise of NCDs, it's important that we understand those critical mechanisms that you mentioned. For example, we should look closely with the impact of unemployment, poverty, low levels of education, or what one can call health literacy in terms of NCDs. It tends to be a condition that as Africans, we are quick to find solutions in our traditional beliefs. You very often see people thinking that NCDs are a curse or NCDs are happening because maybe the ancestors are not happy. So there's a lot of work to be done when it comes to education and health literacy. And indeed, on the continent, we have high levels of unemployment, and that also impacts the ability of our communities to access care and to receive the care that we need. So in short, I can say that there is an issue with social marginalization. When it comes to NCDs, you obviously in the basket, we can add mental health. We know how communities usually respond to mental health, and indeed, poverty and unemployment are playing critical roles when it comes to those drivers of inequities in outcome for NCDs on the continent. Thank you.
Thank you, Dr. Patrick. You shared a lot just to understand how we have so many factors contributing to NCDs. Now we can go further to explore more factors. Then, Dr. Orighoye, you can take us through how do healthcare access and distance to access healthcare facilities, geographical barriers can shape the NCDs intervention, especially can make people feel vulnerable for NCDs intervention.
Okay, thank you. I'd like to thank you, Dr. Patrick. He tried to put something that I was about to tell him that's good. So about the factors. Normally, I will go with the typical example based on the work we do here at Rwanda, in Rwanda with 3S Rwanda. Typical example with the district we're currently working on, like Burera district. So it's all about in Africa. We have a limited transport. So we found the transport, not only transport, but also the infrastructure. It's not easy to reach people where they live. So we found like one hospital in each district, which is also the one of the risk factor that can lead to the consequence of that NCDs. Another thing is the cost of of health, because when you see about the insurance, let's think about the strategies taken by our government of Rwanda. I don't know, Patrick shares how they are doing it in their country, but most of the time we meet the high cost of the insurance. Another thing we see here in Africa, it's about the training. We are facing the low healthcare providers, but also like in Rwanda, we have a system where the community health workers are the first person to take care of the people in their village. So like here in Rwanda, they have a limited trainings for those NCD screenings for community health workers. So you will see most of time based on the experience, when we are screenings at the level of the health centers, we found people saying that we're not informed about this, which means they don't have information about NCDs. They think it's another diseases. You'll find people dying of disease like complication of diabetes, like diabetic retinopathy. People say
I think we are losing you, Dr. Olivier.
oh, I'm available now. So very sorry.
Okay, proceed, please.
Yeah, I was saying, people in the about the NCDs saying we didn't have information about the risk factors of NCDs. Now they must be flowed about the NCDs. So it's almost the common in Africa about the limited transport due to the infrastructure. You see the cost of insurance. You see the limited number of healthcare providers, even the less trainings. Also, those are based on the villages, because we are not at the level of the Western people who have a doctor in each village. So I can see that I like a limitation or a geographical vulnerability to access health basics as an African people.
Thank you, Dr. Olivier. Thank you for emphasizing the common issues we have in Africa, especially for infrastructure to allow people to access healthcare facilities. But let's consider those who live not only for remote areas. Now let's go back to both remote area and the city citizens. Then Dr. Weyoms, please, especially for vulnerable populations. That now we have gender and culture. So can you take us through the gender and culture issues? How they contribute on NCDs disparities?
Thank you, everyone. Good evening. So just in case you might hear my daughter talk, so she's just around. Gender and culture. I want to thank the two speakers before me. They've touched on some very key things like mental health and transportation. So gender and culture, they are like a double burden also in these conversations of NCDs or the burden of NCDs. So when you talk of gender, I think about the risk. So you have diet and nutrition. Women are likely to eat the leftovers. Women are likely to eat last because again, maybe the proportion of food is not enough for everyone. So they are very vulnerable. And then they also suffer a bit of the triple burden of malnutrition where, oh, if I take a Coke, I'll be fine. Or if I take this sugary drink, I'll be fine. So there's that paradox of what is being advertised, what they have to eat at home, and the sacrifices they make. In the African culture, especially from maybe where I am in the southern part of Nigeria, exercise is not something a woman should do, or physical activity if we don't say exercise. So why are you being physically active? So it might restrict women participation in sports. One of the research I did during my PhD touched on women in sports or girls in sports, and they were like, no, doc, we don't get to do sports. They frown at us. Maybe in the city side, we are seeing women now going to the gym and all, it's changing. But however, we all know that physical activity is not something that it's a risk factor that poses women to have NCDs. We do not shine the light on women when it comes to tobacco or alcohol consumption, but there is a risk. So I tend to joke on my WhatsApp stories and say, in my small town, I tend to joke. I'll say that the women get to use alcohol to cover their mental health issues, which is very true. So in my area, women, because the light is not shining on them that they are drinking or they are smoking or they are taking substances. But however, with the work that we do, we are seeing a lot of women who use that to say coping mechanism. So it puts them to be vulnerable. Let's come to access to care. Some women still are very financially dependent on their husbands. So they depend on their husbands to, give them the money or tell their husband, where are you going to? Or I'm going to the hospital. Why are you going to the hospital? What is wrong with you? And that leads to she has too much work, so she doesn't have time to go to the hospital. So I remember during the times I used to practice, and even now when I'm working, I say, have you asked her why she came to the hospital around 2 a.m. in the night? You don't know what has happened before that time. That's because time poverty is also an issue. There's also a gender bias. Women say, oh, I'm tired, I'm feeling nauseous, and say, oh, you're just tired. You are just tired. Compared to a man who says he's tired, he's feeling nauseous, or is fatigued, women might have little time, so they might have asymptomatic hypertension, which might be delayed. And also because of the history that we have had or delay in systems and, bias, women might have gender bias. So like, if I go and tell this doctor now that I'm feeling like this, I'm anxious, I'm stressed, to say, madam, you are just overworking yourself. There's nothing wrong with you, all those things. So there's a bit of gender bias. And that burden that they are the caregivers is also there. If we come to culture, like Dr. Patrick has already said, we have our traditional beliefs that get to influence this gender thing, this whole thing, this NCD thing. So, a woman who says, I have mental health issues, that means it's spiritual, or, the diagnosis of cancer. So I've had people in the last 1 year in my work and so on keep saying, doc, I'm not sure somebody used this thing to hit her and, all like that. There's also a case of a woman with elephantiasis, and she kept saying, I matched poison, I stepped on poison, but it was just elephantiasis. So, those kind of models of how we view disease. And then there's a lot of stigma as well. And also, whatever communication, like Olivia had talked about, communication maybe it's in English or in French and it's not in local language, so they don't understand. And then we have this distrust. You did not tell me before that there's something called diabetes. When I now get to the complicated part, you now start saying you have complications. That's it, but the health worker that has been treating me did not say that. So there's distrust, and that leads to a lot of barriers for women. So I'll leave it there.
Thank you, Dr. Williams. I think we are lucky to have so many experts to share different perspective on the factors contributing to NCDs inequity. Thank you very much, Doctor. Now, actually, we talked about different factors, but there are another factors we need someone to take us through. We have now politics, we have policies, we have another factors which can contribute to NCDs inequity. I think it's time for Abdul Karim to take us through there to understand how politics can contribute to NCDs inequity.
Thank you. Thank you for having me. Good to see everyone. And I first of all echo all the interventions that we've had around individual determinants, gender, culture. I think they go a long way. But I think when we look beyond the individual context, a lot of these things are driven by political processes and policies. I think the first thing is regarding political will. Just last week was the UN high level meeting, actually this week that just passed, on NCDs. And I'm sure like a lot of, ministers of health, our presidents were there. But the big question is what are they doing back home? So specific example, I am from Nigeria, and in Nigeria we have the NCD strategic plan. So we have like a document, a paper. And when you read it, it's quite ambitious. It talks about specific targets, talks about what the governments want to do. But a lot of time when you're in meetings or like when you have conversations, you just realize that they've not allocated funding for the policy. So like it's just a paper. And it's there's a lot of thinking that went into it, but like it's not been implemented. And then like when you think even beyond the fact that they've had a policy, but what are their plans for implementation? So it's at the time when they want to like have that plan, the action plan, that they should actually be thinking about implementation and have some budgeting for it. WHO has like some targets for countries to spend, I think about 5% of their GDP on health. Yeah, a lot of African countries don't meet that target because they spend money elsewhere. So there's that issue. And in a lot of African countries, Nigeria as well, health is not really like on the agenda in political cycles. So like if we have a presidential election, hardly would you see any candidates prioritizing health and be like, this is part of my core things I want to achieve. And that leads me to my second point around the wider issues. I think that we have a lot of insecurity and conflict. And maybe that's part of why the governments are not able to fund health as much because they are sort of prioritizing addressing this conflict issues. So beyond the impacts that conflict and insecurity have as regards funding health, there's also the issues around like logistics. So like so in Nigeria, for example, there are some specific regions where conflicts is an issue, right? So like if you're living in that area, you have challenges with access to care. Maybe you can't go to the hospital. Challenges with the supply chain. Things are not getting moved as they should. So that's like a concrete issue, and it's a political problem. Individuals cannot solve them. Governments have to like commit to resolving it. The last point I'll quickly touch on is around this multi-sectoral thing. So NCDs isn't it's not like the communicable diseases where you can think about it primarily being in the domain of the Ministry of Health. In a lot of instances, you see, you would have to work with like the Ministry of Trade, the Ministry of Agriculture. Alcohol is a key risk factor, for example, and that is regulated by, the trade and commerce infrastructure that a country can have. And usually the ministries that are in charge of this, they are more keen about profit, right? Like they want to generate revenue. There's all these issues around, having plants and, doing the manufacturing locally. We are trying to say that our people should not be consuming, but the government is trying to raise funds and bring in, industries into the country to produce alcohol and tobacco locally. So like, there's that tension between the Ministry of Health and the other ministries, especially the Ministry of Trade and Commerce. But I think even more importantly, there's an opportunity that has been lost in terms of like the coordination between the Ministry of Health and like the Ministry of Education. catch them young, having Dr. Weyoms talked about physical activity, having physical activities in school, trying to get people educated, health literacy, improving our health literacy from the early years. And that's something that the Ministry of Education can do. So yeah, the really important things that I thought about are around like the political will, these issues that we have around insecurity, instability, conflict, and then importantly, like the coordination between the different government arms, the ministries, especially. Thank you.
Thank you, Abdul Karim. Thank you, Tim. You shared a very great information in terms of exploring the factor contributing to NCDs intervention. We can't forget you talked about much, including culture, gender, social, economic, political way, and conflict, how they contribute on inequity in NCD intervention. So as now we have explored the factors contributing on, let's jump to the needed intervention. Now we have to include community-based intervention, you have to include involving innovation in digital health tools, you have to include funding, partnership, then policies. So let's move to the Dr. Weyoms. You can take us through how I know in Africa, most countries are using community health program, right? So take us through there to understand how community health program, how funding and partnership, this can contribute to improve NCD's care in Africa, specifically in the context of Africa.
Okay, thank you so much. I think it was a very nice way to follow up from what Abdul Karim has said. So I see community health workers as like the engine room of whatever we are doing. So we need to shift because they are the engine room. We need to shift from being passive with them, whereby people go to them to a more we come to you so that they are coming to us. So I'll use like an example. So I come from one of the communities where it's remote. It's when people are coming, they are like, oh my God, this place is very far. It's out of town, it's coastal, and there's not a lot of electricity. So my father and I wrote to the representative in the government of that constituency. And after like 5 or 6 years, they finally brought a health center to us. But we had to adopt the health center as our own. So it's like we have a baby health center. And then since 2019, it has been our health center. So you will hear my father say, you have to keep the health center running. And that that is where I've seen the life and direct of community health workers. So them being the engine room, meaning that we have to go to the people. So we need to shift the dynamics of power whereby we think, oh, these community health workers don't have the power, but they are the ones, they are the navigators, they are the ones that can go into the communities, they are the ones that can talk to the people, they are the ones who can have that continuous care. We talked about transportation, but when the community health workers are living in the community, Nigeria has a funny thing whereby we bring in health workers that are not based in the community. So they take 2 hours, 3 hours to come. So we need to acknowledge the community health workers. We need to train them. We need to equip them. So for example, not saying, oh, we need $5 million to equip them. It could be as saying, do we have an NCD kit? Do you have your blood pressure cuffs? Do you have your medicines? What do you have for essential things just to find out that, okay, we have dictated the case, we have a reading, we have this, we have that. And once we are able to identify or empower these community health workers and appreciate their work, the funding that would come in that will be sustainable, we now need to start thinking, okay, how do we professionalize these community health workers so that they have regular salaries? One of the challenges we have is the government is paying less than $2 to community health workers. It's so small. Many of them are 2 hours away. So people like us who have adopted health centers, we are now looking for fundings to say, okay, we'll put you on a payroll. So when we think of sustainable funding, we need to think, how do we put them on longer, regular salaries? Another thing is the fact that they are there regularly, they see them. So my organization does what you say, community round. So we go door to door, we ask questions. So because they know us, you start hearing they say, they call us by our CMADI, are you here? This my leg, this my urine is blue, this is that. So because they know what there is more reliability. It's not that the health center closes and then in 2 weeks it opens. People wouldn't trust it. And then, like Karim said, we need multi-sectoral whereby health and agri comes together, health and social service comes together, health and all sorts of them, they all come together rather than us isolating them and say agri is working on its own. No, health and agri. Oh, how are we going to say nutrition? How do we signpost someone who has mental health issue? How do we signpost this person who needs maybe microfinance or anything? So I think we need to think about they as the engine room. How do we keep them going? And then how do we work together as a team, not everybody isolated?
Thank you, Doctor. Actually, you share a lot on this point. I think now everyone understands the intervention need to address those factors. But let's just make a brief and shed light on some key points, especially for policymakers, how how policymakers can contribute in shaping equitable solution. Let's Dr. Patrick take us through there to understand how the role of policymakers in shaping equitable solution in Africa. Just to shed light there.
Thank you, Michee. And yeah, the question that we received also spoke of the role of communities. I think we cannot dissociate the two. And reflecting on what Abdul Karim said is very critical. Everything starts with the policies. Everything starts with government. Unfortunately, there are some changes that that we are talking about that can only happen if a minister sign a document or if a president take it as a crusade or as a personal initiative. Therefore, advocacy is so critical. As public health professionals, as people advocate, people living with NCDs, communities at large, it's so critical that we understand how those things work. For example, among the NCDs that we are talking about, we have diabetes, which is in the rise in the continent with so many cases and so many complications. As we grow up, we always have a positive association with companies like Coca-Cola or McDonald's when it comes to, it's actually even aspiration. When you want to reward a child, you offer him a bottle of Coca-Cola. And it becomes so entrenched in our psyche, in the way we are considering things, that we fail to even see them as a danger to our societies. So therefore, those people in the background, they are also doing a lot of influence when it comes to our policymakers. It's so critical that as communities, first we need to realize that the power is within our hands, not only to be in charge of our health, as Dr. Weyinmi just said, but also in understanding that those industries are in the background influencing our policymakers and our leaders in making that decisions that sometimes are against us achieving health equity, achieving health outcome, even for NCDs. Therefore, it's really critical that we understand the role of advocacy. It's to put pressure so that the decisions that are made by our leaders are in our favors and not, as somebody says, the tobacco industry or the sugar industry or any of those industries. Those decisions should be in our favor. Therefore, communities need to ask for a place around the table. It's about designing interventions. It's not just about being recipients, but it's also about being part when the design of those interventions are made, and even going forward in even influencing the policies that our policymakers are taking. Yes, policymakers play a critical role. As we said, we need to have an ecosystem that is in favor of not only preventing those NCDs that we are talking about, but also providing care where care is needed. Therefore, it's important that funding is allocated. What Mr. Abdul Karim mentioned is very critical. We have so many policies, but then when you start asking the critical question, you realize that there's no budget. How would you implement things when there's no budget? When you prefer to buy guns and weapons instead of funding those critical policies that were put in place. So yes, not to make a short story long, but to emphasize that it's so critical that as communities we need to take power. That's why I'm very glad that such an initiative like this Fire Chat is happening. It's in terms of informing, educating our population so that they understand what is at stake here. And I will really invite people who are on the socials. There are some of those issues that I'm breaking down in my newsletter on LinkedIn. And it's very critical that us as professionals, we start leading the charge in terms of informing our communities and also influencing our policymakers. It's very critical that we play that role so that eventually we can reach outcome and we can combat inequities in health. Thank you.
Thank you, Dr. Patrick. Actually, as now we have a diverse team following us and we see this conversation, thank you for sharing the message for policymakers to understand the use of communities in the decision-making table. Thank you very much, Doctor. Now let's take another step from just discussing the community and the policymakers. Now we are going to move to the technology. When we talk technology, there's some team, community, vulnerable communities who are not missing on this table of technology. So now let's understand how digital health tools, even if the people they are not using so much technology, but they have to benefit from technology. So, Dr. Olivier, can you take us through the digital health tools and how they can be adapted to support vulnerable groups? Dr. Olivier, are you there? I'm not sure if Dr. Olivier looks like his network cut off. Let's move to the Abdul Karim, then we come back with Dr. Olivier. Now we have, even if we are discussing issues and intervention required, but we have some intervention already took place in Africa. So can you take us through to understand it? Just share us an example of a success advocacy initiative for vulnerable group in Africa. We can just consider as an example for this intervention.
Thank you.
Okay.
Yeah,
Thank
I
you.
think this question is quite critical. It's looking like all gloom
Okay.
and all bad things happening. But they are so success. I think that's the summary. I think the first one that comes to mind for me is the alcohol policy in Ghana. I think that it's so comprehensive that it might even be like a gold standard for any country. Right. So it's quite comprehensive. So if you read about it, you'd see that so in terms of affordability, so people being able to purchase alcohol, they have a high excise tax duty. It's about 47, it goes up to 47%. So it ranges between the level of alcohol that you have in the content, which is quite high. Sadly, some African countries have like 5%. So you can understand when I say that they are quite ambitious in what they are doing. They do have a ban on endorsements for celebrities. Even though like we know that there'll be people trying to find a way around it, etc. But it's quite ambitious to say that influencers, celebrities cannot endorse alcohol. That's quite strong. And thirdly, there's the age limit, which a lot of African countries would say they have. But I think overall, the alcohol policy in Ghana is quite comprehensive. In terms of how they got there, I wanted to share the end goal at first. In terms of how they got there, it's a lot of years of advocacy. So the NCD community in Ghana is led by an NGO called NCD Alliance. Ghana NCD Alliance, I think that's what they are called, Ghana NCD Alliance. And, they basically have different CSOs, different NGOs coming together and doing several years of advocacy. Part of the things that they've done that I am aware of is that, they would have meetings with MPs, they have trainings for journalists. So they're not just influencing what's happening in the House and in the Parliament, but they're also influencing what's going on air. So like, they have fellowships or some training sessions, workshops with journalists, and then they do a lot of community outreach. Like they also engage the people. So that's sort of like what got them to where they are. So years of advocacy, meetings, and it's signed. So all of this I'm saying is it's not something that's still on paper or being discussed. It's already signed and being implemented. So that's one major success that I look to when I think about the political landscape in the region. The second thing for me is the decriminalization of suicide in Kenya. So in terms of vulnerable communities, mental health is quite key. A lot of people suffer from mental health condition, and in a lot of communities, Nigeria inclusive, mental health is seen with, that stigma. Suicide, for example, in Nigeria is still punishable under the judiciary. So it's not a health issue. So if you commit suicide or you attempt suicide, it's not a health issue. It's a justice issue. So you are going to be tried, basically. And I think they had similar laws in Kenya before. But after years of advocacy, they've gone to the point where it's been decriminalized. So there was a ruling earlier in the year, I think in January, where the High Court in Kenya basically said it's unconstitutional, and they've walked back the penal code. The penal code still exists in a lot of countries, but I think it's important to highlight where that kind of success in Kenya, and hopefully it motivates other countries like Nigeria, other countries that have such code to walk it back. The suicide is not a crime. The third thing, because I've really talked a lot about how Nigeria is struggling, is the mental health bill in Nigeria. And this is also like a lot of advocacy from communities, that organizations I can talk about, the mental health, mental health. I can't remember their full name, but they're called Mani. She Writes Woman is another advocate from Nigeria. So a lot of really, really strong advocates coming together. Also similar to what happened in Kenya, meeting with the parliament, doing a lot of advocacy with the president, and they went through a process. So the mental health bill was signed in 2021. It was passed in Parliament in 2021, signed in 2023 by the government. So it's gazetted, it's already signed, and it's just following up on implementation. Obviously, having a document or having a bill is the first step, but it's a win that they were able to like get that across, and have something that's a law basically, and it's somewhere to build. So yeah, I think like as much as we've talked about some of the challenges and things that are not really working, I think we can see some light. Ghana with the alcohol landscape, Kenya with suicide criminalization, especially because that's been signed. And a lot of African countries still have that penal code. And also like the mental health bill in Nigeria as well. Thank you.
Thank you, Abdul Karim. Quickly, let's go back to Dr. Olivier. Dr. Olivier, we want you to share with us just to link like digital health tools with intervention, NCDs intervention to vulnerable groups. Just briefly take us through there.
Okay, thank you. I'd like to start thanking the first speakers. We have started saying about the limitations and the risk factors. We have seen about the area they live, about the transport, the cost, even the socioeconomic status of people we are talking. We're saying vulnerability of them, which means they have some limitations to access some basics needs in their life. So about technology also goes to them, which means most of them we found them not having smartphones. But we have to make sure they can have other ways to get information related to the NCDs. So when you come to health tech in the NCDs, it's for me, I go about it there. It's about the follow-up, because after going there in their community, you've screened, you've identified some people with hypertension, with diabetes. So the next step is about how we're going to follow up them. So it means some technology just to remind them, or to make them get adhere to medications. For me, about the technology, I'll go with some of the strategy being used by government of Rwanda. So we see every second and fourth week of the month, every Rwandans get a message saying, remember that you have a massive spot, and they tell you the location and the why you need to do that sports. So it's a kind of reminder. So to help people, they need an appropriate language in the message you are sending them, to really understand why it is needed to do sport, to do early screenings, or to tell them the consequences of the NCDs. I will start to say about the diabetic retinopathy as the complication of diabetes. So also about the NCD patient, we need NCDs clinics where they have the identification of each individuals. So to make sure that when it comes to the time of follow-up, they have to send them a message, a real message, not an app or software, because you understand they are in rural areas, or they are vulnerable. That's why you are saying they are vulnerable. They don't have access to some technology, but they have small phones, mobile phones. So they need we need to have NCD clinics with a patient identifications, to ensure that we know the time to take medication and the time to do a follow-up. To help him or her to get that information, you need to have a system which will have to send him or her a reminder message. Also, a reminder message with a message telling him or her the necessity of taking that medication is about consequences or complications. Although we can say about that, but the people who we say they are not vulnerable, also they need this information, because of most time we have said about the risk factors, about alcohol use and the tobacco use, smoking. So we can say that those vulnerable are those who live in rural areas, also can live in urban area, but being vulnerable to NCD information, because we have seen that most of the time people lack information related to NCDs. So I would like to suggest to everyone, we'll see in the comment when you start about question and answering of the discussions, we really need to identify the people with NCDs, and we need to tackle the stigma of saying that NCDs is age related only. We need people. We need to tell people about the factors, because we find a young man like me smoking at my age, it means I'm risking myself to the many diseases, respiratory diseases. Also, we need to identify those patients also with the awareness and education. So I'll come up with the experience we had with the partners in health and the Butalo Hospital here in Rwanda in the Ibura district. We used to screen the retinopathy as the complication of diabetes. But on our area, we take the phone number of those people. We identify them, we take their phone number, then you go there to the hospital, we put them in the system, then we take it as our responsibility to send them the message. Please, we have identified this hypertension or diabetes in you, and you need to come to the hospital on this day via message. You don't have to use a complicated things like an app. You go on the app, you see the rendezvous, and you will come to go there. You identify them, you take their phone numbers. Then you put them in a system because you understand they are people in the rural areas, they don't have smartphones. Then we send them a reminder, which is appropriate in appropriate language to them. So, saying on this, firstly, by summarizing, we need first to identify the people who have NCDs with their ages. And the next, they need awareness and education because they need to know the risk factors. And the next, they need to know the complications. After that, you have identified them. You've said about the risk factors, awareness, education. You need to have the identifications within your system. It can be in a written box based on the region where they have those technology. So you have to send them a message reminding them to come to the hospital to do a follow-up or medications or to see whether they had no other complications. This is the way people in our areas can get basic access to health. Also, we have said about the limited trainings to the community health workers. I've understand even in Nigeria, they use that system of community health workers. That's good. Those people are playing a big role in our community. They need to be trained about the screening of NCDs, even reporting. Also, that's a technology that it's a digital health. They must be trained to do a screening of especially hypertension. It's not a big deal to know a BP, even a heart rate. Also, diabetes, they need to be trained about that. So after identifying the case in their village, it's better to report it to the health center. The health center can report to the hospital to meet a doctor for the follow-up. So I'm trying to connect with the area we live, not having a complicated technology in serving a population. We need to use a technology which is how can I say, which is easy for them to understand. It's a message from the hospital to remind you when to take medication and when to do follow-up. And it's for a community health workers to identify case because understanding they need to be trained about screenings. After screening, I have seen this based on the training you've given me. I've seen a patient with a BP of 160 over 120. Better you can follow up. It's a small message to the identified or focal person at the health center. Then it's easy to report it to the hospital and the doctor can do a follow-up. So on my side, we use that way just to do a follow-up and to identify those people with NCDs, and it worked. It worked and it's still working. If you understand, as an NGOs, we depend on the government policies because as Toyibu said, the policymakers they have a big role for every people, every person. So anything you do as an NGO or a company related to health, you have to consider government policies and you have to include them on the things you are doing. So that's why for us it worked about our experience on the screening of diabetic retinopathy as a complication of diabetes. So, and people get follow-up and most of them, they got the eyeglasses for who had high complications, and others, they are now being followed by doctors at the Butaro Hospital. I think it's a good way you can adopt even in Nigeria for people who have a lot of technology, even in the population where say they don't know how to use smartphones. It's easy to use only message. You take the number, you've identified they have NCD, then you do a follow-up and medications. So things like that, it's easy, not doing complicated things. But if for this world they are going in, where every person have a smartphone, it will be easy for everyone to have that an app or a software. It can be easy for giving every Rwandan a message or every Nigerian.
Thank you, Dr. Olivier. Thank you for sharing a very, very important insight and giving a very tangible examples on your intervention. For the sake of time, but we still have a discussion. As we discover the factors, then we have discussed the intervention. Let's go through the different role of stakeholders involved in that intervention, and then how this intervention and implementation can be sustainable. Let's go quickly, just shed a light on the key point to understand this. Dr. Orighoye, you have to continue the talk by sharing us the how. Usually we see government, we see NGOs, each one has its own vision, but let us understand how government, NGOs can work together just for sustainable, equitable focus program, especially for NCDs in vulnerable communities. Briefly.
Thank you. I will continue with that I was saying about, as an NGO, in our mission, it's about health, identifying NCDs. So you understand, as an NGO, you have for us, it's a youth led, you have young people who have trained for that, who have background in health, the nurses and the medical doctors. We go there at the level of the village and the level of the health center, we identify cases. Then our job, it's now, I can say it's all about 90% over, because we have already identified the cases. But as an NGO, we don't have hospital. That's where the government take their role. So after identifying, it's easy to hand off to the hospital. Hospital belongs to the government, so they be the one to take care for that patient. So as an NGO, the next role is to do a follow-up. You have identified the cases. You have to make sure they are going to the hospital and they are being followed. Also, they have got medications for the cases you've identified. So I think that's where we have to be linked with the government without talking too much. That's how I see things. As an NGO, we have to identify things. Then you have to hand over to the hospital or health centers. Then to be the one to give medications, other things and the follow-up. But as an NGO, for the good of people, you have to do a follow-up for the cases you have identified. Are they being followed? Are they being treated? Have got the medications or the care they have to have. So that's where, as an NGO, that's why we play a role. And for us, I think for the district, Rwanda district, we have got about the 80% of people who have identified with the diabetes and hypertension. Over them, they are being followed at the hospital. So, and we appreciate ourselves because we did a great job. We identified the cases and the people are being followed. So it's a big journey, and Patrick and the Toibu, even Weyinmi, they will share their experience about that, the people with NCDs and how they are being followed and treated. Yeah. Mr. Michee, I think that's all for sake of the time.
Yeah. Actually, thank you, Dr. Orighoye. For not taking too much time, let's go through. Actually, you have talked so much theories. Let's take some practical insight from Dr. Weyoms. Just let us go through the most practical steps just to scale up the interventions, but considering equity.
Yes. Very interesting. I think Oliver has already started. So I think one thing we keep saying, we are doing a mindset change, and that involves not thinking that NGOs are fighting government. That's something. So you are not being aggressive to government, because it doesn't work that way in Africa. You have to learn to liaise. You are bridging the gap, filling the spaces alongside with the government. So when you want to talk about scaling equity, so because I've adopted a health center, a primary health center run by the government, so I can give like practical. So first of all, so let's say we have women who have we're noticing their readings are high postpartum, and then what do we do? So first of all, we say we run a pilot project. So I think we need to move from thousands and millions of pilot projects into changing a system, whereby the things we are doing, whatever we are scaling, is now everyday thing. It's not a special project. It's not a project that has a five abbreviation word and all of that. So it needs to be like an everyday thing. It's not a special project. So whatever project I'm doing for diabetes, who's the most vulnerable and how did it work for them? Don't just give me the ingredients. Tell me what happened. How did it work? And then doctors, scientists, researchers, academic people, they get to shy away from the table, the policy table, but that's where advocacy comes in. So who is paying for it? I find myself writing to MPs and all and saying, hey, please put this in your budget. Please put this in your budget. And sometimes it takes 5 years, it takes 10 years, but there's that, write a letter to them, talk to them on social media, wherever you meet them, tell them this is the budget. And one day, they would pick it up. Again, the next thing is, whatever I am doing in community A, can a new person, a new village, a new community, a new primary health center, can you take that up in the next 3 months? Can they start whatever I'm doing here? So you're trying to have non-negotiables. If I say I'm going to be doing readings and all of that, can somebody else also replicate it in 3 months? And then also government, what are you going to do? How are you going to train your staff so that they know the basics of this? So that's where NGOs come in, academics, institutions are coming, everybody is being on the table. Who is going to train the next 1,000 workers? Who is going to take care of them? And then before we jump into the next health center, we need to think, okay, what did we learn from here that we can fix first before we jump into the next place? And then we need to assign, there's a lot of we, when we are talking, we need to do this, we need to do that. Who is the we? Is it the matron at the health center that is doing that? Is it the coordinator at the local government? Is it the local government chairman? Is it the director of programs from the NGO? When we start thinking about this, it's no longer a special project, it's now an essential equitable service. So thank you.
Thank you, Doctor. Thank you very much. Let's get another insight from Abdul Karim. Usually we have covered everything, but let's see if we have missed something, Mr. Abdul Karim, especially for healthcare providers. How can healthcare providers deliver responses to care, but considering culture factor?
Thank you. I think a lot of this have already been captured. I'll start by saying that I'm happy to stay for longer. I know we are like tight on time, but it would be great to hear from the audience as well. So I think I'll just reiterate what's been mentioned. Healthcare workers working in communities, vulnerable groups. The first thing is co-production. Dr. Weyoms, described it succinctly. Health is not in a vacuum. Whether you're a health worker, you're a doctor, you're a nurse, if you're going into a community or attending to people, keep that in mind. Try to ensure that you involve them in that process, even if it's their care, even if they are the one coming to receive care. Let them feel some ownership that when I go to this hospital, it's not like my agency has been taken away. Somebody's just talking down at me and shouting at me, but like it's a collaborative work. And even if it's in terms of like community projects, Dr. Weyoms talked about adopted health facility, thinking about ensuring that the community is embedded in whatever you want to do. The second point I'll talk about is around health education and literacy. We've talked, a lot about, today about how people might not know a lot about NCDs, might not know a lot about the risk factors. So it's really important that health workers keep that in mind, whether people come in for something else. So every touch point should be an opportunity to discuss things, especially maybe if you see potential diseases developing. If your patient, for example, has some issues with their liver because they are consuming alcohol, it can be an opportunity to tell them about XYZ, your blood pressure, hypertension, any family history, all those kind of things, and just take that time as an opportunity to spread the gospel. The third point for me is around sharing our stories, and I think a lot has been shared today. So we talked about some of the challenges, and we know that it's a lot. But I really think that when we have success stories, they should be shared. So like healthcare workers should keep that in mind. If you've implemented a project somewhere that's gone really well, the community has taken ownership of it, it's working, write about share it with your political policymakers when you meet with them and let them know that this actually works. It's working in Ghana. It's working in this community in Rwanda. So like let's share these success stories. And part of that is also like doing some research. So like let's quantify those results. Yeah, I've done this project, but like, what has happened? What has happened before and after? Is there something documented? Is there something published? That goes a long way in terms of like strengthening the work into the future. I'll drop a link in the chat box for somewhere where we can share some of the stories that I've been hearing today. An example I would like to spotlight from there. So it's a WHO page. It's called WHO Knowledge Action Portal, and they have two streams where they get stories. There's this one called the NCD Labs, which I'm part of. So people sort of like enter a kind of competition, and then a winner gets published. But then there's another one where you don't necessarily get to go through that review, and you're able to share your country case study. There's a specific example from Ghana that I saw last year that was really good. They were trying to do something around community advocacy, community outreach. So they would take a van into communities in Ghana, and they would have they would do health service. And in that opportunity of doing health service, they would also do like education. It's like comprehensive, and when you read it, I know we are tight on time. When you read it, you get the gist. So like let's leverage that people power, share our stories, get people involved, do that co-production bit that I talked about, and yeah, try to work collaboratively. Thank you.
We're saying about the experience there in Ghana and even Nigeria, and I would like to know how I'd like to ask it to you. How like here in Rwanda, maybe it's somehow resolving. And the government is doing their best just to have the infrastructure. And understanding Nigeria is a big country. So how do you try to reach people that just to about the first is about the education on health. The next is about the flow up, even the screenings. How do you approach the people there in the rural areas, especially where it's not easy for the government, because we see ourselves as NGOs, we try our best to stick where the government don't want to go. And they identify the case, you come up with the ideas. Government, you have to go there and see how we can help the people who lives there. So I'd like to hear the typical experience from Nigeria. How do your best just to reach people, especially with NCDs as the topic of today?
Thank you. I can make a start. Dr. Weyoms is also from Nigeria, and I should add the caveat that I'm not currently living in Nigeria, so my realities might not be perfect. I think the first thing in terms of what I've experienced or seen is people leveraging technology. So there's a lot of leveraging technology. And I think typically we think about the traditional technology like, mobile apps, AI, and all of that. But the challenge is that not everybody have that knowledge to be able to use it. So I think I see projects that have used things like USSD, text messaging, SMS, even like the basic technology tools to reach the hard to reach people. So that's the one thing that comes to mind for me. The second is the obvious, like the different apps that people have, the different tools that people use. I think that goes a long way. And I think people also use a lot of traditional media. So like, using radio to do communication, telling people about the risk factors, the diseases, and what to do. The other thing that I've seen is regarding mobile clinics. So these are hard to reach areas. Governments don't have, established infrastructure there, but typically people do like community outreach. So they decide on a day or a period of time, they go into that community, they do some work. And the best of them are usually the ones that are not one-off. They're usually the ones that are like sustainable. So you have some plan behind your project, and you're just trying to go to a community and just touch and you tick a box. But you're trying to actually do something, and you have a plan that maybe you go 3 times, 4 times, and you think about sustainability. Maybe you're trying to train the communities to keep up the work when you're unable to go back. Dr. Weyoms. Do you want to add something?
Yeah, sure. I understand. Yeah, as NGOs, we need the advocacy. We have to advocate for our beneficiaries. I think is the best thing we can do. So in the chat box, I've seen a guy called Alexis Nshimayesu. He was asking whether he can have a time to talk about the volunteers. I don't know whether he's still there. Alexis Nshimayesu, where are you?
Yes. Hey, I'm there. I'm available.
Yeah, okay. You can share. I know in Rwanda we have the medical students associations where medical students at their level, they used to go in their community near the university, even far from university. They do screenings under support of Rwanda Biomedical Center, WHO Rwanda. Then they identify cases, as I said, and they put to the nearest health center. Then they do follow-up. You understand? It's a big role played by those young people at the university level. Alexis, where are you?
Yeah, I'm available. Yeah.
So you can share with us your experience at Medicine, what you do there, just to train people in Huye, even far from Huye, where our university located.
Yeah, okay, thank you. I am now in Red Cross, where we sometimes go in rural areas and teach them about non-communicable diseases and their preventions. For example, even today, we have been on the church, where we have been teaching people about, for example, let me say, mental health issues, and then how they are related to family conflict. Yeah.
Okay, thank you, Alexis. And my question is going to Dr. Patrick. Patrick, these days, I've been there to the RBC, it's Rwanda Biomedical Center. They're trying to combine a department of mental health with NCD department. So please, for on my side, I can have a few information. How going to correlate mental health with NCD? Is it depression? Is post-traumatic things related? Also going to be considered as NCDs. Please, can you correlate about diabetes, hypertension, depression? How the mental health department is going to be in the department of NCDs? How we're going to be in the same department? NCDs with mental health issues, how going to be the same as NCDs, to be considered as NCDs? I think you understand my question.
No, thank you. Yes, there's a move toward integration. People, obviously, when we are talking about from a person-centered approach, a person living with diabetes might as well have depression. A person living with cancer might have mental health issues. Some of those mental health issues could be separate. Some of them might be due to the primary diagnosis, either cancer or diabetes or stuff like that. So when we are talking about integration of services, or in the context where you are talking or you are mentioning where a department now combine NCDs and mental health, my position is that yes, it could be the way to go, but we still should understand that the way you address, for example, mental health will not be the same way you address diabetes. The priorities that you might have for mental health, for example, in our context, is about a lot of stigma a lot of changing our old ways of addressing mental health, where we used to institutionalize. Some people were even put in chains and stuff like that. There's a lot of work that we need to do in terms of going more for community-based approaches, going more for a human way of addressing it, and obviously the stigma and the lack of understanding. But the needs will be different in diabetes. So integration of services shouldn't be at the detriment of one disease against the other. We need to still have this holistic understanding, and so that whatever solutions that we are bringing in are informed by evidence, but are also adapted to our context. I think for a lot of issues, we tend to just want to copy maybe the recommendation from WHO or from other bodies. It's important as Africans that we find solutions that are working for us in Africa, that consider our culture, our cultural diversity, our past, and our resources, our availability of resources, and so on and so forth. So yes, integration might be the way to go, but obviously we need to understand the rationale. Is it because we want to save funding, or is it because we understand that it's a whole-of-person approach? And even in that sense, you still have to have experts in the specific field. It's difficult when, for example, in our countries, we are expecting a nurse to be able to do mental health and to be able to do diabetes and hypertension and schizophrenia. It's difficult. Even that's why we have those specializations. So we need to find ways to ensure that at the end, the people come up on top, that the people are the priority, rather than us trying to find shortcuts. So that would be maybe my word of caution when it comes to integration. It might be the way to go, but we need to think about how we do it.
Thank you, everyone. Sorry I missed a bit, but thank you for sharing your insight. And as now we have gone through factors contributing to the NCDs intervention, especially for vulnerable communities. We have gone through the intervention required and the stakeholders' role and the sustainable implementation of those interventions. I think it's time now, as we discuss much, it's time for the audience to express their question so that our speakers can share their technical insight on those questions. Everyone following us, the floor is yours. If you have a question, feel free to raise your hand or post it in chat box. Please, your questions are most welcome.
Michee, we had the time to interact with our audience. I don't know whether they are still there, but we're discussing with the audience. We had an experience from Alexis, who had an outreach today about any mental health issues they were having, awareness and education. So we didn't see any other who were raising the hands for any further question, but the floor is for them. Just it was about the what we were doing before. You can, thank you.
Okay, thank you very much. Anyone, if you have any question. Now we have Dr. Weyoms raising a hand, please go ahead.
Yes. Sorry, I would go first because I wanted to add on to what Dr. Patrick had said.
Can you hear me?
Yes.
Yes, please. I see. Wait a bit.
Yeah, I think thank you so much to every panelist. This was so interesting and exciting. And somewhere I typed that it was good to see Weyoms. It's been a while. And also happy to see Olivier. And I've got an opportunity to learn some of the work that they do. And my question, I don't think it's really a question. I wanted to know each from maybe 2 words from each panelist. What are your hopes as this work continues? What are your hopes on the work that is being done on NCD in Africa. So we talked about any challenges and maybe the experience that happening and the contextual aspect of this movement. But what are your hopes as the day goes by? Yeah, that's my question.
Thank you, Emma. I think who's this question is for? If you can choose one from our speakers to answer your question.
Yeah, I said it's like one or in 1 or 2 words, so and I would direct it to each panelist to share their hopes in 1 or 2 words. So yeah, each panelist. Yeah.
Okay. Thank you.
I can start. No problem. So he's saying it's all about sustainability, because when you come up with the hope of what you are doing today, what will can you say like results. So it's about what Patrick and Toibo were saying. We need to integrate. No, NGO, it's not government itself. It works within the government. So we need to work closely with the policymakers. And also, when it comes to NCDs, we understand it is a leading cause of death to many people. You understand, because of their complications. You understand, from hypertension, from diabetes, even those related to respiratory diseases. So our role, it's our linkage. We have to be the link of the patient, or we have identified with NCDs with the health institutions, health institutions or health facilities. So doing that, it will be easy for those who are identified to get care to identified or to health facilities. Other things, we need to have a project which trains our community health workers, because they are there always to help us to identify for the cases that it can be sometime we don't have funds to go there or don't have time to go there, but having a community health worker who is trained to screen for NCD, diabetes, it will be easy for all people living in that village to know their status about the NCD, whether diabetes or hypertension. So for me, on my view, understand, we need to train our community health workers about screening NCDs. Also, we need to work closely with the policymakers to understand our big role we're playing to identify these cases. So it's in my view, Patrick, even Weyinmi will help us to tell us their views about these things. Thank you.
I can go next. So for me, I have 2 hopes. The first one is regarding funding. What gets funded hopefully gets done. So my hope is that all the African countries would meet that minimum 5% of their GDP on health. So like we need more funding for health. My second hope is that we leverage people power, that we have, strengthened communities, all of us, the NGO sector, even the professionals, the healthcare workers, communities, the people living with NCD, so like the people affected by these conditions, all of us, we leverage our voices, we work together collaboratively to demand more from our governments, because at the end of the day, this is not, it's not just a condition of what I do. That's why I'll be, maybe prevented from having NCDs. There's a lot of structural, wider determinants. Secondhand smoking, for example, I can't do anything about it, even if I don't smoke. So like we need our collective voices to demand more from our governments. So 2 things, funding and our voices. Thank you.
Yeah, thank you very much, speakers and the audience. I think based on that this discussion is very, very interesting, insightful, and is concerned for every African community. So I think if we go discussing one by one, it's going to take us like the whole day discussing. So let's say that the questions are many, but let's ask the audience, please stay patient. We usually conduct the fireside chat twice here. So I think your question, you can share your question, you can give you the email so that you share your question and you share whose this question is for, so that we come up later with the suitable answers from our speakers. So for the sake of time, allow me to just highlight some key takeaway for everyone here. I think from the discussion, we have understood that NCDs inequality and NCDs intervention for vulnerable communities, it's highly rooted in various factors and is affected by various factors. We have highlighted social, economic, culture. We have highlighted the conflict issues. We have highlighted political ways to influence the intervention. So we have to know that the factors are many, and we have also highlighted so many interventions to address those factors. We have to be reminded that community approach, community-based approach is highlighted as the most one we need to focus on. We have gained insight on digital health, funding, partnership, advocacy as the most important tools for equitable intervention. Later, we have emphasized that the sustainability intervention require partnership with both government, NGO, and community. So government ownership, partnership, along with capacity building is important to sustain our intervention. Let's make a call for action so that we close our event to address NCD inequity in vulnerable communities. This is not just a health issue, it's a social justice issue. So each of us, either you are a researcher, you are a policymaker, you are a healthcare provider, you are a community member, a community leader, you have a role to ensure that there is no one left behind in the fight of NCDs focusing on vulnerable communities. Thank you very much, everyone who contributed your time, your insight, everything you contributed for this event. We really appreciate it. Please stay tuned that this recorded is going to be uploaded on our YouTube channel. So if you want to go through this later, you can go to our YouTube, then check one by one and different insights shared during this event. Allow me to say thank you, and stay tuned that every year you receive any communication from Engage Africa Foundation regarding another interesting topic to discuss. Thank you, everyone.